Cancer originates as a genetic transcription error within the host's own tissue, rather than an invading foreign pathogen. This single error activates specific genes called oncogenes. Once switched on, oncogenes act like a jammed accelerator pedal, driving the cell to divide continuously without stopping. Mutating cells remain biologically human. Treating the disease presents a brutal paradox. We have historically relied on non-selective cytotoxicity, poisoning the host just enough to kill the cancer without killing the patient. For decades, primary treatments meant flooding the system with broad-spectrum chemotherapy or aiming static beams of radiation at the tumor bed. These methods kill all rapidly dividing cells, causing severe systemic toxicity and extensive collateral damage to healthy tissue. Modern oncology is moving away from this blunt cytotoxicity toward a model of precision targeting. The field is shifting from a purely biological discipline into an engineering discipline. Clinicians now combine molecular mapping, immunological reprogramming, and computational processing to dismantle tumors layer by layer. The goal has moved beyond the physical limits of excision. Successful treatment now requires solving a complex problem of information targeting. The first layer of this precision stack requires mapping the exact genetic and molecular signatures unique to an individual's tumor. Sequencing the tumor's DNA allows oncologists to identify specific structural flaws. For example, a mutated cellular receptor, such as EGFR, might sit on the cell surface and continuously transmit signals, ordering the cell to replicate. To counter this, engineers designed tyrosine kinase inhibitors. These small molecules match the mutant receptor's anomaly, entering the cell and locking into the faulty hardware. Once attached, the TKI severs the signaling cascade, physically cutting off the division command and halting tumor growth. While TKIs block signals internally, other engineered proteins, known as monoclonal antibodies, attack the problem externally. Monoclonal antibodies are designed in a lab to seek out and bind to specific antigens on the surface of cancer cells. Once attached, they act as a highly visible homing beacon, flagging the rogue cell so the host's immune system can find and destroy it. This shift to molecular targeting replaces the blunt force of broad-spectrum toxins with the surgical disruption of specific survival pathways. Tumors do not exist in isolation. They construct a localized environment around themselves, known as the tumor microenvironment, or TME, which acts as a dense immunosuppressive shield. Within this microenvironment, cancer cells deploy a deceptive biological defense. They develop surface proteins that physically bind to the host's T cells, the white blood cells responsible for fighting disease, effectively switching the immune cells off. To bypass this defense, oncologists use immune checkpoint inhibitors. These agents enter the microenvironment and sever the connection. By blocking the tumor's ability to deactivate T cells, checkpoint inhibitors remove the brakes, allowing newly awakened T cells to dismantle the cancer cell. Beyond passively unblocking T cells, researchers are now actively training the immune system using therapeutic cancer vaccines. Traditional preventative vaccines are given to healthy individuals to stop an infection. Therapeutic mRNA vaccines are administered post-diagnosis to target an existing active tumor. To deliver their instructions, the vaccine's mRNA is encased in lipid nanoparticles. These tiny lipid bubbles must penetrate a specific type of immune cell, a dendritic cell, fuse with the membrane, and release their genetic payload inside. The dendritic cell reads the mRNA instructions and begins presenting tumor-specific neoantigens. Neoantigens are newly formed proteins resulting from the tumor's unique driver mutations. The dendritic cell displays these proteins to CD4 and CD8 T cells, teaching them exactly what to hunt. The efficacy of these vaccines depends heavily on the tumor's profile. Tumors with a high tumor mutational burden, meaning they have many genetic mutations, and an already active, inflamed microenvironment, respond with significantly higher success rates. Reprogramming the host's immune system to recognize and hunt neoantigens offers a higher probability of long-term remission than continually injecting decaying exogenous toxins. Even with advanced biological targeting, removing the primary physical mass often requires radiation, introducing a difficult spatial problem. The human anatomy is constantly shifting. Between the initial diagnostic imaging and the actual treatment date, tumors grow, shrink, and change position relative to surrounding healthy organs. MR-guided adaptive radiotherapy solves this by imaging the tumor at the exact moment of treatment, allowing clinicians to adjust the radiation beams to the tumor's new, precise location. But there is a severe computational bottleneck. Traditional human-driven treatment planning requires days of manual calculation, making real-time, same-day adaptation physically impossible while a patient waits on the table. The breakthrough tool is artificial intelligence auto-segmentation. Algorithms instantly analyze the MRI, drawing precise boundary maps around the tumor and adjacent healthy tissue. The AI automates contouring and complex dose calculations, compressing hours of manual computation into mere seconds. This algorithmic speed allows the clinical team to adapt the radiation plan on the fly, neutralizing the risk that the tumor has progressed or shifted since the last scan. The accuracy of modern physical radiation is now completely dependent on computational processing speed, eliminating the mechanical limitations of the past. The precision stack operates within a larger ecosystem, the human host. Interventions like caloric restriction, a structured diet, and regular physical activity function as measurable clinical modulators of cancer risk and treatment tolerance, rather than general wellness advice. This chart shows how metabolic syndrome, including obesity and high blood sugar, creates a biological intersection with the tumor microenvironment. Systemic metabolic dysfunction directly increases cancer onset and recurrence rates. As glucose and fat rise, the microenvironment becomes densely immunosuppressive. These systemic host factors act as a baseline dial, actively modulating the efficacy of the immunotherapies deployed at the microscopic level. In a coordinated sequence, an mRNA vaccine trains the T cells, checkpoint inhibitors breach the immunosuppressive microenvironment, and AI-guided radiation accurately shrinks the primary physical mass. This triad is supported and amplified by strict metabolic and lifestyle interventions at the host level, ensuring the body is primed to accept the treatment. This integration of disparate systems carries immediate professional implications for modern clinicians and hospital systems. Recent literature warns that AI and computer science competency can no longer be outsourced to external tech companies. That expertise must live natively inside the clinic. In the 19th century, physicians faced a similar crisis of adaptation when they first had to integrate raw laboratory science into standard clinical practice. The French physiologist Claude Bernard laid down the foundational philosophy of experimental medicine during this era. Bernard established the axiom that a physician must not separate the laboratory from the hospital. Instead, they must integrate both methodologies within themselves to create true medical science. Because modern radiotherapy is already an entirely computer-based discipline, the clinician cannot separate the medical objective from the digital tools used to achieve it. To maintain medical oversight, the modern oncologist must internalize AI expertise as a core competency, just as their predecessors internalized the laboratory. The clinical mission has expanded from mechanical tissue removal into a complex workflow of genetic sequencing, immune engineering, and algorithmic automation. Successful treatment now treats cancer as an advanced information processing problem.